Hi guys, thank you for tuning in to Autism Empowered. This is Batul Mirza, bringing to you important conversations and topics that empower you as a parent to help your child thrive. So I've been getting a lot of messages from you guys. I know so many of you have been confused trying to figure out whether Leucovorin is something your child could benefit from. There have been facts and there has been fiction, all mixed in one. As a parent, I get your confusion. These are confusing times, and hence I invited someone whose advice I trust. Over the years, Dr. Armen Nikogosian has become a beacon of wisdom for me. Very rarely you will find a practitioner who will navigate ethics, functional medicine, and intuition, and still make a difference. I should know, I have worked with too many. And hence I have brought Dr. Nick on because I know this is the need of the hour, and we need a voice we can trust to help us sift through this. Thank you, Dr. Nick, for joining me. How are you today?
I'm good. Thank you, Batul, for having me. Certainly any chance I have to talk about autism, kind of get the word out that there's things we can do to treat it. I always take that opportunity, so thank you. I appreciate that. So my name's Armen Nikogosian. I originally trained as an internist. I did hospital medicine, kind of primary care, that kind of stuff. In 2010, my second son was diagnosed with autism. That really kind of had a huge impact on me, not only personally, but it kind of really made me pivot my whole career. I'd always been interested in kind of integrative functional medicine, but pulling the trigger, so to speak, professionally is kind of risky, or seems risky at the time. Of course, now when you do it, you can't imagine not doing it. After that, I kind of changed my professional focus, really primarily onto autism biomed, which is really functional medicine, is what it really is, which is a bit of a rebranding of the old integrative medicine. There are some differences, but since 2016, we've been running our clinic here in Las Vegas. We see patients from all over the world. Probably about 50% of our patients are autism. In particular, we see everything from high functioning to level 3 severe non-speakers, kind of come one, come all. And then the other aspect, we also see adults. With a lot of the adults we see, though, is autoimmunity, kind of immune dysfunction, gut issues, mitochondrial dysfunction. A lot of the same problems we're dealing with in autism, frankly. It's just, a different presentation and different age group. So there's a lot of crossover between the two. Cerebral Folate Deficiency, which is going to be the topic today. That's been kind of
a burning question on everyone's mind. I think since the time that article from Daily Post kind of went viral, followed shortly by that video as well that everyone shared and reshared and posted. I mean, you and I both know that the trials have been available and the research and the studies have been available way before 2025, but they just haven't had this much global attention the way it's had now. I wanted to, before we even get into the meats and bones of what Folinic is or what cerebral folate deficiency is, when did you come across it first? What was your personal experience? What drew you to it?
When I started sort of learning more about autism, going beyond the basic psychiatric diagnosis, so to speak. So when I first heard about it, actually was probably 2013, 2014, as I was learning. Back in those days, there was no blood test. The only way you could diagnose it was through lumbar puncture. So there was definitely limited data available. A lot of people, particularly with an autistic child, lumbar puncture, the only way you're going to really achieve that is through anesthesia. So a lot of people would be leery about doing that. I think it really took off in 2015 when the blood test became available, because that really opened up, to how many people you could really test for it. And we started seeing, the numbers were shocking, frankly, how many kids on the spectrum had the folate receptor autoantibodies. It was just a huge number. We'd see up to, well, some of the estimates in the literature, up to 78% of autistic children have folate receptor autoantibodies. I mean, that's almost more than 3 out of 4 kids on the spectrum.
Yeah.
That doesn't necessarily translate to cerebral folate deficiency as a disease, but it means you got to at least consider it. You got to look. You can do a treatment trial and see, because this isn't something you want to miss in a child on the spectrum, because it really has. If you don't diagnose it and they have it, your other treatments will be limited in terms of how much benefit you're going to get from it.
And I think, Dr. Nick, there are nuances to this, right? Like, you may have cerebral folate deficiency, but it may not work for you to actually get treated for it. The child may just not take to it, or you may not have access to it, or you actually have the symptoms, but then you go and you get tested and you find, well, the test wasn't conclusive, or, well, I'm testing negative, but then you may just do a trial and you see the results. How do you navigate these nuances? They're very confusing for a layman.
Yeah, frankly, it's confusing on the professional side too. It's not. I wish it was like a plus minus. If it's a plus, they all get better. Minus. So the idea behind the folate receptor autoantibodies, right? And that's the thing we're checking for. There these antibodies that are created, and you can have they're a blocking or binding antibody, and one of them blocks the folate from getting into the brain. The other basically binds the receptor. The end result is the same. It basically stops it from going in. It just does it a little different method. So folate is a critical component to neurological development. You have to have a certain amount of folate, and a lot of times, if you just check, a lot of people will be like, well, we checked his folate level in his blood, it was normal, or sometimes even high. Unfortunately, because what we're interested here is the level of folate in the cerebrospinal fluid, in the cavity that holds the brain in the spine. It's a separate cavity in the body. It has its own barrier and everything. That's really the level. So when that folate is blocked, you don't get the normal development. Even if you're doing everything else right, you've got that limiting factor holding everything back. The idea behind the treatment is that you're flooding the system with folate, and a specific form of folate called folinic acid, which is an activated form. So it doesn't require conversion compared to, say, folic acid, which is the synthetic form found in most commercial vitamins. That does require conversion, and a lot of our kids have trouble with that. We want to make it as easy as possible, and all the studies were done on folinic. So you flood the system with a pretty significant dose. And the dose is, the average child requires about 400 micrograms of folate per day. We're treating, depending on the weight of the child, anywhere from 50,000 to 75,000 to 100,000 micrograms per day. So significantly higher dose. Thankfully, it's a water-soluble vitamin. There's really no known toxicity with it, and we have decades of experience using these high doses now. So it's a fairly benign treatment in that regard. So anyway, you flood the system to overcome this blocking and binding antibody, and that excess kind of gets into the cerebrospinal fluid. This is where it gets a little complex, because it does make a difference. Does the child have mitochondrial dysfunction? Does the child have gut dysbiosis? Does it, all these other issues that we works in conjunction with it, because they are all involved in how that folate is metabolized. And then also the folate level itself has an impact on your mitochondrial function. So that's another sort of vicious cycle we're trying to break as far as normalizing some of their metabolism. And then the other aspect of it is going 100% dairy-free. The protein.
That's going to be my next question to you.
That's usually the hard part of the treatment. Because it'll actually make those antibodies sort of stickier, so to speak. So if you don't do that aspect, you could still see improvement with the treatment, but it will be only a fraction of what you would have seen without it. Wow. So that's kind of a non-negotiable component of the treatment. If you want to treat, that's part of it. You just have to do that. You have to do dairy-free while you're doing it. Otherwise, you really don't know. And it's actually, I would say it's even more critical if you're doing a treatment trial, because you're really, because you don't have a test result, you're really depending on the response of the child. So again, it's not something you want to miss because you didn't want to get rid of ice cream or yogurt or something like that. Coconut yogurt's pretty good these days, so you can switch over.
It tastes hard. I tell families all the time, you know what? There's no real good replacement of yogurt, so just skip it. Find other snacks. But
Yeah.
question for you, camel milk, is that still okay because the casein protein is so different in that, or no?
So there's a difference of opinion amongst different practitioners. There are practitioners out there that feel all mammalian milk products should be eliminated.
Okay.
And there's practitioners that feel it's more cow milk specific or casein protein. I'm kind of in the middle on it. My perspective on it is if you're doing a treatment trial, so
May
we
as well.
don't have the lab available to us, I tend to say all mammalian milk just because the stakes are high. We got to know what the response is. So, in case there's some obscure thing that hasn't been studied that we're not sure of, I'm asking them to do it for 3 months. I say all of it. If we have an actual diagnosis from the lab, we've already confirmed the child has responded to treatment, and someone say they've been on treatment for several months and the parents want to try to introduce camel milk. Usually, I'd say, well, because there are benefits to camel milk. It's a good antiseptic on the gut, and its nutritional profile is pretty good. In those situations, I kind of tell families, well, there's a difference of opinion. Go ahead and try it. Tread carefully. Pay attention to your child. If you notice your child's having tantrums or having trouble at school after you start it, that could be something there.
Yeah.
So that's I kind of played a little bit in the middle and try to use kind of clinical judgment as best I can until we get more definitive answers from the literature, which hopefully we'll get one day.
Well, yeah, or you could be living in Canada where there are no camels and there is no camel milk. So
Yeah.
that makes that decision rather easy.
Yeah.
What are the children? What's the profile of the children that you think when you see them? Is it just all right, the child has a diagnosis, I'm going in and I'm gonna do a treatment trial, or let's do a test and see? Or are there certain symptoms that stand out to you as a practitioner? I just want parents to have that understanding when they're observing their own child that I want to actually explore folinic acid or cerebral folate deficiency.
Well, I would consider it in all autistic. I would consider evaluation for this in all autistic children. And when I say that, I know the autism diagnosis is very broad these days. And what I mean by that is where autism is causing some sort of disability in the child's life, whether it's communication, social, bad coordination, whatever it may be. But if it's negatively impacting their life in any way, you want to evaluate it. For myself, when I'm really looking at it, like I said, I kind of look at it across the board. In some of the higher functioning kids that I see, particularly if they're 11, 12 years old and they've got full communication, autism is still impacting their lives, but in less of a format. I still do work it up. It's just not as much of a priority because number one, the child is older. They've already shown a lot of normal development, but in the severe level 3 kids, particularly the ones that are unable to communicate, I mean, it just across the board, we have to have an answer on it one way or another. Interestingly, in the studies when they looked at the kids who had binding antibody, they actually showed that their redox potential and some of the inflammation, because inflammation is kind of a hallmark of autism, chronic inflammation. The kids that were binding antibody positive actually had less redox problems and not as much aggressive inflammation as we saw with some of the other kids. And they think that may be one of the reasons why we see some dramatic responses, because those other issues have to be addressed, and those other issues are not necessarily fixed by just giving folate. So you have to do kind of a full, kind of comprehensive approach. We're not quite sure the links there. When we looked at kids that just had blocking antibody, they didn't have that better inflammation profile or redox profile, but they did have increased levels of B12. So then that kind of brings in that question as far as, those tended to be the kids that maybe benefited more from like B12 injections or popular treatment that does work for a lot of kids. So there definitely is some differences in profile between them. Then you've also have the kids that have certain genetic variants like FOLR1 or SLC19A1. these are not genetic problems that specifically create the folate receptor autoantibodies with cerebral folate, but these are genetic problems that can compound these issues and make them worse. So it's important to identify those as well as a secondary thing. So there are some kind of minor profile differences between these kids.
Yeah, like I said, so nuanced. And I would, in fact, share the personal story here as well. When we first started working with Dr. Nick, I think my son had turned about 6, 7 years old, between 6 and 7. And my son's had, like, he's got speech and he's had language.
Your son's awesome, yeah.
he's doing well. He's doing well now, touch wood. But the thing was that he was stuck at a plateau. And I came to Dr. Nick saying, I know I'm missing something, but I don't quite know what it is. I've done the work on the gut and I've done the work on the diet and I've, we're as clean as we can be from the holistic perspective, but his speech kind of stuck. So we had the expressive language, but somehow the receptive or the cognitive was not kind of catching up. They both weren't balanced with each other. And when Dr. Nick suggested, what are my thoughts about Folinic, I said, let's go for this, because I know that with my son's profile, he'd always benefited from B vitamins and the methylation, and we had the fall R1 issue as well. So I'm so glad that we did it, because like I said, the light bulb moment, the aha moment, and finally we started having our expressive language catch up. So you picked on the right one. You were intuitive about that, because we have no access to testing. Like, I mean, I've heard of families who've gotten frat tests done in Canada, but it's a nightmare. Like,
It's tough. Yeah,
it's tough. Yeah.
Well, that's where you sometimes just do the treatment. I mean, I think an important point to bring up too, like you said, your son had been 7. My son was 7. My son is 17 now, and he has cerebral folate deficiency, and I diagnosed him when he was 7, and that was 10 years ago. That's when the blood test first became available. And I had known about it a couple years earlier, but I was terrified of exposing my son to anesthesia, because he had a surgery when he was very young. Between that and some vaccinations, I mean, that kind of led to his regression. Yeah. So I had an issue with the anesthesia. That's why I was concerned about it. So anyway, the blood test came out. I was over the moon. I was like, great, let's go do it. So, and we did it, and it came back positive. So I started treating him. A lot of families I've talked to, because they read in the studies, like, well, the kids do best if you start at 2.5, or the best results were when they're under 5. Well, that's true in general in autism, I would say, for any treatment, including cerebral folate deficiency, but that doesn't mean just because you haven't diagnosed it by 5 or 6, you just kind of write it off. You still get improvements. Okay, maybe not as profound as when the kid's 2, but I mean, maybe they are, who knows? You can't go back and find out,
They
so,
were both guys, so I don't think that age should be a factor holding you back at that point.
Absolutely. And a matter of fact, I have adults, non-autistic adults in my clinic that I have done the FRAT test on. They came in with mental health issues. They came back positive. We treated them for cerebral folate deficiency. Their mental health issues got better, in some cases resolved. So I think this is actually a more far-reaching diagnosis. I think the reason why it's so focused on autism, the incidence or the prevalence of this in the autistic population is just exponentially higher than the regular population. So there's definitely something going on there. But it is present in the regular population as well. And this is my idea from my clinical experience. I think it's expressing through mental health issues in neurotypical individuals. There's a lot of work that still needs to be done on this, but it's not a hard test to get if you have somebody with, an adult with refractory mental health issues. It's something I would look at. It's not a hard treatment to do. Once you say goodbye to ice cream and yogurt and accept that, it's not that hard. So.
Well, maybe not coconut yogurt, but the coconut milk ice creams are a little bit better.
Yeah. Coconut ice cream's come a long way in the last 5 years.
Yeah, they have. They truly have. They've taken off. Would you say, okay, so let's tackle this one. Is there a specific difference between leucovorin and folinic acid? It's been getting used interchangeably, except the one is cheaper than the prescription drug. But is there a specific difference between the two?
Yes and no. So let me start with there's no clinically significant difference that we know of, okay? One thing to keep in mind when you're buying something over the counter versus a prescription, at least in the United States, the way the law is set up, the dosing can be with generic pharmaceuticals, the dosing can be within 10% of what the stated dose is. If it's a brand name pharmaceutical, it has to be within 1% of the stated dose. And if it's over the counter, there's not really a general guideline. I mean, generally comes in there, but the quality control is not quite as good. So does that mean that the over-the-counter stuff is garbage? No, not at all. I think some of it's very good. I just think you have to kind of go with the old kind of consumer buyer beware. Talk to people that have used it. Look at reviews. Make sure that you're seeing it. The thing that the reason why I like to use the prescription leucovorin, and it doesn't have to be brand necessarily, I'm okay if it's generic, is especially when we're doing a treatment trial, we are putting so much decision on how this kid's going to do over the next 3 months. We have to make sure that the product is what the product says it is. And once we've established that, and then the family wants to branch out, get something on Amazon, whatever, sure. At that point, we have a clinical status that we can compare it to, and then we can see if the kid's going to change or not. But at least in the beginning, when we're making that decision, strongly recommend getting the actual prescription leucovorin or prescription, it's also known as calcium folinate. One of the other differences, so that's one. One of the other differences is that the leucovorin is what's called a racemic mixture. So you have what's called Folinic Acid and dextro, right? It's left hand and right hand. So one is like this and the other's like this. They're the same molecule. It's just the way they're oriented. One of them is metabolically active, and that's what does all the work inside. The other gets fully excreted. So a lot of these formulations are 50-50. So half of it you're excreting, half of it you're using. You can get some that are 100% the levo. Here's the interesting thing, though. You would think if it's all metabolically active, you're going to get more of an effect. But clinically, there's no significance between the two. Kids seem to do just as well. So that's why I was kind of saying yes and no earlier. Like, that's a pretty clear difference, but doesn't seem to make a difference in terms of how the kid responds. Because whatever that metabolically active piece is, and the question I have too is like, how do we know the part they say that's excreted that's not at all metabolically active? Like, I always question that. They know it's metabolically active towards this particular process, but does that mean it's not doing something else?
Yeah.
Maybe it is. So I think the clinical significance piece, meaning how is the kid responding to it, I think that's really the key there. And it doesn't seem like there's any difference there. One other point too is the leucovorin, particularly the one made by Pfizer.
Yeah.
It does contain lactose. It does contain dissolving agents, so there's some additives in there. In a particularly sensitive kid, I have not seen much issue with it. And to be clear, the dairy-free piece they're talking about the protein, because the protein creates the immunological reaction. Lactose is a sugar. Sugars do not create immunological reactions. So, that's neither here nor there, But some kids are real sensitive. Some parents are really apprehensive. We get the lactose-free, no additives, no dyes, no colors, and that's perfectly, that's perfectly fine. There's plenty of compounders that will do it, including one in New Jersey that we'll send to Canada. So, yeah.
Yeah. I know which one you're talking about.
Yeah.
Okay.
I'll leave the plugging to you, but but yeah. So there's a lot of options there.
Yeah. Okay. And I think that clarifies the piece, because there are so many questions about. I actually took the liberty of checking on US Amazon, and I found that all the folinic acids were sold out. And I was like, this is next level insane. Because our parents just literally running off to Amazon or iHerb and just purchasing these, supplements, thinking that this is it, and actually wanted your insight on that, because we know this is nuanced, and we talked about that, we touched on it a little bit. Is this how cerebral folate deficiency works, or folinic acid may work? Just, maybe trial it and use the over-the-counter products and you'll find a difference. Isn't that more like silver bullet, chasing silver bullets?
It's absolutely chasing silver bullet. Look, I'm not opposed to it. I think anything that could potentially help our kids at whatever level of access the family has, I support it. My only apprehension with it, and it's a big one, frankly, is this whole kind of silver bullet chasing, thing, which we all do it, right? We all want whatever disease we're dealing with, we want it to be straightforward. If you have diabetes, if I can get your sugar normal, and we keep it normal, we've essentially gotten rid of the diabetes, right? It's pretty straightforward. It's pretty much focused on what that blood sugar level is. Autism is not like that. It's not one factor, unfortunately. This is an important factor in some kids, very important factor that needs to be addressed. But the problem is, even if let's say you treat your kid, you give this to them, they do get better, most likely there's a lot of other issues going on. Yeah. And we know that from decades of treating autistic kids. I mean, there's an actual, back about 5 years ago, a group of doctors proposed a medical diagnostic criteria for autism rather than a psychiatric criteria, which is what we're currently using, what we've been using since the 90s. The medical criteria actually is pretty good. I mean, a majority of the kids I treat I could, without ever seeing a psychologist, I could have diagnosed them with autism just using the medical criteria. That's how common it is. So, and these problems are pretty varied. You have methylation disorder, you have mitochondrial dysfunction, there's chronic inflammation, there's redox issues. Because of those issues, we usually see a lot of gut dysbiosis, toxicity issues, whether it be metal, mold, pesticide, the laundry list and stuff. These are complex kids, very, I see some very complex patients in my clinic, and hands down, I've been doing this now over 10 years. My autistic kids are still my most complex patients by far. And then if you add in the lack of communication, that just adds a whole nother level to it, because now you're doing a little bit of veterinary medicine where you kind of have to guess what's going on. You can't exactly ask the kid. So that just makes it even harder. So yeah, it's complicated. I would tell families out there that are doing that, I'm good, help your kid, do whatever you can, but this isn't the silver bullet. It can have a significant impact and definitely help the child, but there's probably other issues. So I would really just get in contact with someone that can kind of unravel these issues and just fix them, little by little. So.
Yeah, and we can guide you through the whole nuances of it, because and I totally get that. We, by hook or crook, we want to help our kids, right? Mm-hmm. And there are no rules around that.
Right.
But you could have that whole silver bullet mentality sitting in the driving seat, and then the decisions that you make get influenced, and they're not always the best decisions. If you take a step back and look at the whole picture, you could do your digging around, you could do your research, you could get in touch with Dr. Nick or myself and, study more on what exactly are the things that we're talking about today. And I think that you will make better decisions just by having that awareness and that clarity. No one's saying don't follow or pursue this. I mean, me and Dr. Nick will be the last people to say that, since we both saw great gains with that. But it is nuanced. It's not as simple as buying it off Amazon and trying it at home. And I really want to discourage that mentality, because it may actually work for your child if you do it right.
Yeah.
And I don't want you to miss out on that.
And even if it works, I mean, that's fantastic. Run with it, but realize that what you're seeing there, you could get even more. If you kind of correct these other things. And like I said, the complexity of this, I mean, I still to this day, I look at some of the old charts, someone I treated back in 2015 or 2016, and I look at it and I feel like I'm kicking myself. I'm like, oh God, why didn't I do this? Why didn't I do that? Like, I know myself how much better I'm treating kids now, 10 years later. And I'm sure 10 years from now, I'll look back on my charts I'm doing right now. That's just the nature of medicine, and we keep getting better at it. And particularly with autism, the treatment options have really dramatically expanded in the last 10 years. And the challenge now, 10 years, when my son was little, I mean, there was limited options, things we could do. So you kind of do them all. You kind of, throw everything against the wall, see what would stick. Today, there's hundreds of things that you can do. And if you don't have a direction for treatment, you can really squander many years of your child's youth while you're kind of cycling through these. So you really want to get kind of a roadmap and a game plan in terms of, okay, these are the priorities. I'm going to kind of front load these, and because this is what's probably going to help. Because you really want to get these things on board. The younger the child is, the better. So age is, we're kind of fighting the clock a little bit. Well, more than a little bit, a lot, I would say. I mean, that's, one of the factors there. So that's what I would kind of keep in mind. And, if you don't have access to a practitioner where you are, do some research on your own, or, do it to whatever extent you're able to, just to get as full a picture as possible of your child's situation.
And I think it's really powerful what you said, that, we could get more. And that time, it's a fight against time for each and every one of us. And no matter how old your child is, actually, it's still a fight against time. So
Yep.
make time your friend and work with that time. And it's only possible through really empowering yourself with all that knowledge. And hence the purpose of my podcast as well, that, there's so many questions that need to be answered. Okay, so let's talk a little bit, or touch a little bit on the testing as well, Dr. Nick. I mean, we talked about FRAT test, we talked about lumbar puncture. I don't think anyone is doing lumbar puncture for diagnosing cerebral folate deficiency anymore, or at least I hope not. And maybe in certain cases, it's probably worth it. But what are your thoughts about, is FRAT test really necessary? Like, I know in Canada it's very difficult. I'm not sure about UK, maybe you can kind of weigh in on that. I know from India, again, I've heard parents say they cannot. So like, it's really difficult. I mean, the further away you get from North America, I guess the harder it's going to be. So is it necessary?
So the first thing I guess I would say is that the FRAT testing is done by one lab in Pennsylvania in the whole world. So, and that's one of the things that, because a lot of patients are like, well, I'll go to my local hospital and get it done. I'm like, well, sure, if you can get them to do it, but to my knowledge, I mean, nobody else does it other than this one place. Hopefully that'll change at some point in the future. But as it stands right now, we have one location in the whole world. So there's a logistical issue getting the sample there. Some foreign countries you can get it. It really comes down to how efficient, DHL or FedEx is in that country, and, all that. But it's hit or miss, right? So within the U.S., you can pretty consistently get it. And that's where that treatment trial comes in. The testing, like I said, the blood testing really revolutionized access to this, because prior to that, where lumbar puncture was really your only option. You can still get lumbar punctures, because they're not really, the lumbar puncture, what it's really testing for is a folate level. So, and the advantage to the lumbar puncture is that it'll actually tell you sort of the result of it. Because remember, I mentioned earlier about close to 80% of kids on the spectrum have some folate receptor autoantibody. It's like 8 out of 10 kids. I mean, that's a huge number. But then when you look at the number that actually have cerebral folate, it's closer to about 45%, about 40%. So you've got a big chunk there, about 40% chunk of kids that have the autoantibody but don't seem to have cerebral folate receptor or cerebral folate deficiency. So that, anyway, that's the advantages to actually see what that level is, because it'll tell you if it's low or not. One of the challenges we have, I have sent a couple of kids for lumbar puncture. Sometimes we get an equivocal result on the FRAT test, where basically one of the antibodies interacts with one of the reagents, and you get this thing, it's like SFR, which essentially means it's not positive, it's not negative. I treat those as positive. So far, the numbers of the kids I'm treating match exactly with the numbers of the positive kids. So, but sometimes parents are, they want further proof, or, further follow through, then we do that. The testing itself, like I said, it's a binding and blocking antibody. Binding by far is what I see a lot more of in my clinic. When I see both positive, usually those are the kids, very high proportion of response. If I just see binding, we'll still see around 40-50%, something like that, that'll respond. So regardless, even in a worst case scenario with sort of the most flimsy results, you're still looking at about half the kids getting better. So it's always worth a try. That's why it's such a high yield thing that we want to address.
Can you shed some light on the dosing? I know the dosing that was discussed or done in the research was between 0.5 milligram to 2 milligram, but I understand you do high dosing, and because that's, I guess, the whole point, right? We want to flood the brain with the folate. So yeah, how exactly does the dosing work?
The dosing that I use at my clinic is 3 milligrams per kilogram per day, and that's pretty standard in the literature, but The literature is broad. They go as low as 0.5 milligram per kilogram per day, all the way. Highest I've seen is actually 24 milligrams per kilogram per day, and that was actually given IV, and that actually showed a reduction in seizures, which is not something that you typically see at the other doses. But anyway, 3 milligrams per kilogram per day, pretty standard. There is, I do sometimes go higher dose if they have moderate to severe mitochondrial dysfunction, because you need that. If your mitochondria are dysfunctioning, you're not going to have as an efficient crossing of the blood-brain barrier. So we try to compensate for that. The challenge is kind of tolerability initially, because to get to these high doses, some kids are great. When you get to those doses, they just take it in stride, no problem. You get them to the target dose, but at least about half the kids do get some degree of hyperactivity or insomnia, aggression, anxiety, kind of fill in the blank, like basically overactivated. But that's always transient, and I always tell families, just hang in there. Just slow it down, take your time. On the one hand, you're like, oh my God, we found this thing. I want my kid better. They want to get them to that target dose as soon as possible. I totally understand that, but it's not up to us. I always tell the parents, it's not up to me and it's not up to you what the pace of the treatment is. The pace of the treatment is dictated by the child. So if you're going too quickly and the child is bouncing off the walls and sleeping 2 hours a night, biting his sister and doing all this other stuff, you got to tone it down. You got to back off a little bit, because it can do that. It's the whole goal of this treatment is to turn on their brain, right? To activate it. And just like anything, you can overactivate something. And overactivation, probably like a panic attack would be maybe an example of overactivation where you can't turn your mind off. Imagine if you're inducing that in your child. I mean, they're not going to respond well.
Yeah.
So, but again, it's easily remedied. You just tone it down, slow it down. Maybe it'll take a couple of months to get to target. If it is what it is.
It is what it is.
You just have to do that. So.
But there's a school of thought as well, right? And I want to touch on that because when this whole thing went viral, there were two schools of thought that emerged: the under-methylator and the over-methylator theory. The Walsh protocols and so on and so forth. But how does folinic acid, because it's a whole different, it's almost contradicting each other, the whole thing. We're going very high with the dosing, we're trying to flood the brain, but if the child is an over-methylator, I guess this is not going to work.
I think the way methylation works will have an impact on this treatment, certainly. But also conversely, I mean, in a kid who's a poor methylator, say you're doing a treatment trial, you don't know if they have cerebral folate, and you just have them on, like, say, 5 milligrams of leucovorin, which is actually a big dose for the earthly dose. It's huge, but for cerebral folate, that's kind of a nothing dose, right? They start getting better. And then it turns out, you go higher. Sometimes the improvements you can see is just from supporting methylation, because leucovorin will support methylation. Even, a lot of times people think, well, it's got to be methylfolate to support methylation. It doesn't. Methylfolate and folinic acid, they're only one step apart from each other. They're both active forms. The topic of overmethylation is, I don't doubt that overmethylation can certainly occur. My issue with it is I still don't feel there is really to me, it's still in the realm of theory.
Yeah, I agree.
I've been hearing about it for 10 years, and I've been very interested in it, but I just don't see anything concrete as far as issues that occur from it. So are we probably over-methylating some of our kids? Yeah, we could be, but we have very clear knowledge of what the outcomes of under-methylation is, and they're pretty significant. Not just in autism. I mean, it's a broad issue, actually, across the board. You can make the argument a good chunk of mental health issues are from undermethylation. So we know treating that will significantly decrease the disease burden and improve clinical outcomes versus the theoretical ideas of what overmethylation are. So I'm just not sold on it yet. So that's my
reality trumps theory, basically. At some point.
Yeah, well, I'm open to it, and like I said, if there's evidence that comes out that tells me to back off, I will. Yeah. But I need a clinical result that shows me, hey, this bad thing happens if you do this. Yeah, if I see that, certainly I would factor it in. But right now, the bad stuff from not having enough, far outweighs it because we got a whole volume of that we've known about for decades. So that's kind of my angle. Listen, medicine's not perfect.
Yeah.
I wish it was. I wish we could do perfect treatments. But you go for what's going to give your child the best shot at having the best outcome for themselves. And it may come with some baggage. It's possible. I think the baggage with the leucovorin treatment is minimal to none. I find it to be extremely safe. My son has been on massive doses for over 10 years. I know dozens of kids that have been on it for well over a decade, 15 years. So we have a lot of experience of kids being on it for many, many years at these high doses. We're really not seeing any issues whatsoever. Is it possible something could happen after 30 years? Maybe. It's possible. I don't know. But I can tell you right now, 10 to 15 years where we have a lot of examples of that in kids that we're actively seeing, we're not seeing anything. All we're seeing is good stuff. The main side effects are short term. When you're first titrating that dose, definitely that overactivation thing is real. That definitely happens in a lot of kids. You can get bad sleep, hyperactivity, so you got to watch that. But once they get through that and they get to that threshold where they're used to the dose, it's kind of smooth sailing. Then it's just about arguing whether or not they can have the cheesecake. I mean, that's the big challenge,
That brings a question about the cheat meals. Are cheat meals okay, or is that like completely throwing off the scales here?
I mean, they're probably not okay, but I mean, do I listen? My mom's Russian, and she does a big New Year's thing, right? New Year's is a big deal to Russians, and she has a New Year's party, and she makes cheesecake. And my son Jonah, he loves his grandma's cheesecake, and he does not eat cheesecake the rest of the year. And when we go to her house for New Year's, he is having that cheesecake, and he gets upset if he doesn't. Should I stop him from having it? Yeah, I probably should, but I let him have it. Yeah, and yeah, he does. He's a little foggy the next day. So's the rest of the family, a little hungover or whatever. His is just a different reason, So, but within a day or two, I think if it's something that's sporadic, kind of special occasions, probably not a big deal. Within a day or two, you can kind of recover from it. But I think it's how you define what cheating is, right? Like if it's every Wednesday, that might be a little excessive, and it's also, I think, kind of evaluating what happens with your child. The only tricky part about that is that there definitely can be subtle changes that we may not pick up on. So that's why it's better to really, minimize it. If you got to let it go once in a while for special occasion, as a parent, you got to make that decision. That's a parental decision, in my opinion.
I think it was really powerful, and I love the way you advocated for this, right? Like, this is something that has been done in your practice and by yourself and on a personal level, and you have not seen any side effects, or it's perfectly safe. You've done it for 10, 15 years. Okay, so when it comes down to, is that something for life? Is this something, and like, do you have to be diagnosed with cerebral folate deficiency in order to pursue this forever, or is it a forever kind of thing, or is this something you do and maybe you scale back on a maintenance dose? And what are your thoughts?
Yeah, first off, it could be for life, maybe, right? So possibly, but I can tell you there are also plenty of kids that I've treated that the parents stopped it after a few years. The kid was fine, but it really depends. I'll just do a quick story. I had a kid in my clinic. He was recovered from autism. He recovered around the age of 6 or so, and he had been on the cerebral folate treatment since he was 3. So he was actually in one of the early trials. Now he's a teenager. Anyway, they ran out. Mom was between jobs, lost her insurance, and usually insurance pays for the leucovorin. In this case, it didn't. But the kid had been great. I mean, it totally mainstreamed. Everything was fine. So she decided, you know what? It's like $300 to get it without the insurance. Let me see how he does without it. So she did. So she stopped. And at that point, he was 13 years old. He didn't become autistic again, but there were pretty dramatic changes. He kind of stopped interacting with his peers. He stopped doing self-care, like brushing his teeth, combing his hair, and these were all things he would do on his own. Mom didn't have to hound him or anything like that. So definitely had an impact on him. So in that particular, and we put him back on. Everything perfectly went back to normal in like a couple of days, no problem. a situation like that, probably, maybe it is going to be for the rest of his life, possibly. But I can tell you, I have just as many, case studies of, after a few years, the parents stopped it and the kid didn't seem to need it. And I think in those cases, what we're probably seeing is that the folate receptor autoantibodies, they're actually going down, because we do know that they can actually diminish. So, and that gets back to the other point we had where, your kid has multiple medical problems if your child has autism, primarily being immune dysfunction, chronic inflammation, mitotic dysfunction. That immune dysfunction piece is kind of central to autism, and there's a lot of us, and myself included, that really view autism as an autoimmune condition. It really has a lot of the hallmarks of autoimmunity. It's just not, we just haven't found like the autoantibody, the autism autoantibody. That's why they don't call it that. But anyway, as that improves, as you improve their immune function, you can see these autoantibodies actually go down or even disappear. So that's why I think, so in those kind of cases, those are the kids. You stop it after 3-4 years and they're good, and they stay good. But yeah, at the end of the day, you really have to evaluate each kid individually, but it is possibly for life. And so there is a potential for that. So that's why you want to make sure if you're treating it and the kid's responding, you want to try to get insurance coverage on the treatment, or find as affordable a place, because it's a monthly expense, right? So you want to kind of put all those things in place. And for here in the U.S., I would say most commercial insurances do pay for the prescription, so which is helpful. It's like a $5-10 copay. But and if not, there are different options, and that's where you want to kind of connect with someone that has kind of experience in this, not just the clinical piece of it, but also the logistical piece.
Yeah. And interestingly, there are a couple of doctors that I have come to know about who have started addressing autism from the lens of a cerebral folate deficiency. Their trial dose is quite low from what I'm hearing. It's being done in Canada under the medical care. I'm not going to name the doctors, and there are some, and I've heard, because I'm in touch with so many families, 5 milligram or so, but I'm like, hey, as long as you're addressing it,
Yeah.
it's good enough.
I'll take it. It's better than nothing. Yeah.
Better than nothing. And I don't know if they're using compounded either, because like there are modifications to what the trial, the actual research had certain parameters, and I know that everyone's changed it a fair bit now. Where like Folinic is being sold on Amazon, so we've kind of drifted from what the actual research was and what brought the gains. So I think the way you have explained it today, you've really simplified it. Now we're beginning to understand why this is nuanced and what parents should expect. One question that I have, and I actually wanted to weigh in on my own personal journey, like my son Ayan was on Leucovorin for like 2 to 3 years almost. And then we slowly but surely kind of weaned him off it. I wanted to see what I see, and I learned a thing or two. We didn't lose our gains, but it's exactly what you said. There are other things that turn up. And you go like, well, this wasn't an issue for us before. Why is this an issue for us now? So I think there are nuances, and parents should understand that this is not a one and done thing. This is something that they may need to revisit maybe a few times in the life, or forever, if that's what needs to happen.
I mean, the point I wanted to make today was that autistic kids are complex, and I think we both discussed that quite a bit, and I think just to get that idea out there, and like I said, I'd be the first person to give me a silver bullet and let's solve this simple problem, but it's just not what it is,
It's not what it is, but it's a damn good start if this is where you end up being, and if it resonates with you. You can reach out to Dr. Nick. I'll make sure that everything is linked in the video below. He runs a very successful practice, Southwest Functional Medicine, out of Vegas. As you can see, he's brilliant at this topic and multiple other topics of autism, and so much insight. Dr. Nick, I'm just so deeply grateful, because I don't know if any professionals are actually speaking up about it. I know a lot of parents are, a lot of coaches are, and Daily Mail is, but we need to hear from people like yourself, professionals like yourself. You have the medical information and the insights of a parent, and experience working with hundreds of children. So that's what's been missing for us. And thank you for educating us today.
Well, thank you for having me, and autistic kids is kind of what I do here. So I do enjoy seeing them, and if anybody needs assistance with unraveling this kind of massive puzzle, I certainly will do my best job for it. So.
Yeah, investigative. I will have to bring you back for mitochondrial dysfunction and a whole discussion about that, because that is equally important. It kind of works in parallel from what I've learned from you. So I think that that's an important one to touch, and your insights about apraxia as well. So guys, tune in and share this video, like us, reach out with your questions. I think there's so much more to be discussed here.
We got enough topics with autism. We could pretty much do a weekly series for quite a while. So there'd be plenty to talk about.
That I will take you up on that, Dr. Nick.
All right.
Thank you so much.